If you're not, you might want to leave. Thank you very much. Lovely. So as usual, we've got a few things to go through with you this morning. Please, as I always ask, if you've got any questions, queries, if you want to stick them in the chat, and we will get to questions at the end. Please make me work this morning. Come on, you can do it. And we will go through various things this morning. We've got some guests who want to talk to us about certain things, and hopefully we will be done just before 12 o'clock. Kevin, over to you, I think, first.
Start coughing before Right, yeah, sorry. So governance update, I'll whip through this quickly because there's nothing too exciting. Our usual incident report, showing us where we're at in terms of our incidents being reported across the Directorate and how many are overdue. We don't have a governance manager at the moment. Maf is on maternity leave and is due back in January, and Dee was helping us to cover it, but she's not here any longer with us doing that. So I'm picking up odd bits and doing reports. But so the plea is to all of those of you who do undertake the risk reviews and incident reviews and any stuff as a responsible manager within the systems, please do pick those up and have a look at them, because we're not really able to support you as much as we would like to at the moment, and hopefully come January we'll be back on that again. And for those of you who don't, yes, Claire?
Sorry, Kevin, I was just going to say, I think the really important bit here is we have reported incidents to say that something has gone wrong. And actually, if we're not then reviewing those incidents to look at what went wrong, why it went wrong, and how can we prevent it happening again, we are in theory just causing ourselves additional incidents for the same thing. We're not stopping them happening. And I think it is a little bit of a chicken and egg, isn't it? We then have loads more incidents to investigate, whereas if we just looked at the first one to start with in a timely way, we may have prevented some incidents. And ultimately, a lot of these are around preventing patient harm or harm to our staff. So please, if you are down as one of those incident managers, make sure you just put yourself half an hour a week in your diary to go in and look at your incidents and have a review of them. It should be within all of our roles if we are incident managers to do that. And of course, MAF helps, and Kevin, you're covering a little bit of it at the minute, but it really is up to all of us to check those incidents ourselves.
Yeah, and I was going to say, despite having said that we need to do the work to keep looking at everything, please don't stop reporting your incidents, because they are important. They're important for us to learn from them. It's how we can improve things, how we can make sure things don't go wrong again for some patients or go wrong for other patients, and learn from things. So please don't stop reporting, even though we've got a lot and we're struggling to get through it all. Please continue that high level of incident reporting. I think our trends are fairly normal in terms of where we're seeing our incidents and around medication incidents, etc. And I know there's some work on that in oncology at the moment. So I think the normal trends are going on there. We've got a large number of reportable incidents at the moment in radiotherapy, but that is fairly normal. We do see that happen, and they are being investigated and dealt with correctly. So that's not anything particularly concerning. In terms of risks, that's all the risk summary. It looks very colourful, but the important bit around risks that I will kind of want to say is, please, if you think you've got a risk in your area, we have a risk process for reporting a risk, for getting a risk added onto the risk register. It's on the Cancer Directorate pages. I can send that link out again, and I'll do that in the weekly update this week with how to do that. But if you think there's a risk, if you think there's something that needs escalating, speak to your specialty lead, your DOM for your area. They will have access to add a risk to the risk register, and then it can follow the process. So again, it's all about safety, and it's safety from risks to do with patients, but risks to do with health and safety as well, and risks around working in the Directorate. So again, please highlight anything there. And these are some of our significant risks. You can look through these when the slide deck comes out, if you so wish, but these are some of our significant risks across the Directorate. And if you think there's something significant that's missing off that list, or you think there's something on this list that needs updating, then let your DOM know in your area, and they'll be able to escalate that, or your matron, up for us to then take that forwards. As I say, there's health and safety audits and actions. We're not doing quite as many audits as we were. I know the quality team have picked some of that up. Thank you to them, and have continued to do some health and safety audits for us. And when MAF comes back, we'll continue to work through that with her. And there are current health and safety risks on the risk register. But if there are others, please do highlight them, to the teams, or email Cancer Directorate Governance and we'll ping that back to the right people. In there, we've got a lot of documents at the moment that are overdue review, an awful lot on Merlin. Some have sat there for a long time. I know a lot of people have been working through those, so thank you to them who've been doing that, and our DOMs have been supporting with that piece of work, so thank you to those guys as well. We have an awful lot. I think the next slide is the very, very busy slide that shows you all the people who have all got documents that are overdue review within the system. If there are people on there who are no longer working in the Directorate or are no longer appropriate to have those documents listed against them, then let the quality team know. There are nearly 4,000 documents across the Directorate and lots of people, 900. So trying to keep track of which documents should be which people, which point is always a challenge. So please do get in contact with them and let them know. But if you've got documents coming up for review, it's important we review them in good time to make sure that we've got safe practices for our patients. That's the ultimate important part. And one of the nice slides, our patient feedback. I know we pick out the positive patient feedback here, and I know there's not always that, and sometimes we have some that needs a bit more work, and we're looking at how we can improve that. Kind of, you said we did feedback, but here are just some of the nice comments about the services that we have. And I think when it's really busy and we're all running about trying to do everything, we sometimes forget exactly what an important and valuable impact we have on our patients, and it's nice to see some of this positivity coming back. And I know Ingla's going to talk about the patient experience survey later, and some of that's reflected in there as well. So that's a very quick whistle-stop tour of our governance slide. So Claire's going to do performance.
Thanks, Kevin. I think it's really important, isn't it, when we think about all of our services, to think about the quality and the governance of how we do things, as well as the performance and the patient experience of it. We provide fantastic services, and I'm going to mention it again. Some of you will be bored of me saying this, but if you didn't see our amazing piece on the BBC News, we were on local BBC News last Wednesday night, and then BBC Breakfast, National BBC Breakfast, picked the piece up on CAR-T and CCTL on Saturday morning. So if you didn't see it, please go and watch it. I think it's been shared on all of the trust pages. It's an amazing example of quality of care, patient experience feedback, and doing something really exciting that makes me very, very proud. So well done to those teams. So just a bit of an update then in terms of our performance. So often this is referred to as targets. I don't like the word targets. This is our performance. We have three really, really critical national targets that we are all monitored against at the minute. The top one there are cancer waiting times targets. So those of you that have been around and working cancer for an awful long time will know of these. They've reduced in number this year, so we now only report 162-day performance and the national faster diagnosis target, and those targets have changed slightly, but you can see on a whole there we are green across the board, apart from 1 month in May we had a slight drop. So this means that this is across all of our teams, across the whole trust that see cancer patients. We are seeing diagnosing or excluding cancer, which is the other really important part of this, in patients. We are treating them quickly. We're not quite back to where we were before the pandemic. We used to be above 85% for our 62-day. But actually, when we compare ourselves to lots of other hospitals around the UK, and particularly within the east of England, we are always at the top of those league tables. So really, really positive performance. Thank you all and your teams. It does make a difference, those every day that we save along that pathway. But actually, for me, most importantly, that is a patient who's having a day less to worry about things because we can get their diagnosis and treatment. The middle graph there that we've got, this is our referral to treatment, RTT, 18 weeks, as you may know of it. So we're obviously a long way away from 18 weeks at the minute. The national requirement at the minute is that we do not have any patients waiting longer than 65 weeks for treatment, which I think you'd understand if you are one of those patients with a non-cancerous condition. 65 weeks is an awful long time for us to be waiting. We do have a small number of patients that are over that, and we have one in oncology at the minute who is a lower risk cancer patient who's been referred from dermatology, but the rest are within urology, and we're not quite where we want to be for the end of October, so we will be declaring 8 patients who have gone beyond 65 weeks for the end of October, and we have really, really fantastic plans in place to get that list, that number down by the end of November to 0. And particularly the urology team are working incredibly hard on doing that at the minute. The bottom one there also refers to urology. So this is how long patients wait for the diagnostic tests. And within urology, we have 2 cohorts, that's cystoscopy and urodynamics. Our cystoscopy performance has been fantastic, and we're back down to that level that we need to be for patients who are breaching there. So really great performance. Urodynamics is a little trickier, and we've had a backlog since the pandemic of about 100 patients, and are struggling with our normal resources to get on top of that backlog. So we're looking at various options at the minute. And obviously all those patients who wait longer then wait longer for their referral to treatment pathways. So it does have that knock-on effect. And again, the urology team are doing some work to try and recover that position. But I think really for me, on the whole, it is a really positive story. I know it's hard when we're looking at all of these lists of patients that we've got to book on a daily basis, that the list is huge. It is making a difference. We are getting there. So please keep doing what you're doing. I think my next slide was just a summary of, have I got bullets? Go on, click the, oh no, oh. Have I only got one?
No, you've only got one.
Oh, okay, so my bullet points didn't come through, but I think my general messages are just really think about how you work in your home life. So in terms of efficiency, how do you work at home? You know, do you go to the shop for 1 tin of beans, 1 pint of milk at a time, or do you go for 1 big shop? That's about being efficient. So how do you translate that at work? So let's make sure all of our clinics are full, all of our theatre lists are full, and full of the right patients. So let's make sure we're booking people in the right order. Let's make sure people actually need to come to those clinic appointments, that they've had their CT scan reported before we see them in clinic. Really make sure, I say, we're being efficient with our resources. My other points there that haven't come through are around thinking again about how we spend money. So money is incredibly tight at the minute for the organisation. We are looking at where we can make savings across all sorts of things. So again, think about within your own areas, think about any consumables that you use, think about, opening packets of Clinell wipes, think about equipment that you use in theatre. Oh, Kevin's clicking. Think about, anything that you use, gloves, anything. Do you need to open that next packet? Can we be more resourceful with how we're using things? When we're recording on Epic, think about your check-ins, check-outs, whether you've recorded that it's a multi-professional appointment that patients are attending. All of that makes us money and brings extra money in for the organisation. Think about bank usage. So have you got vacancies that you're using bank for, which is absolutely fine. But when you filled that post and someone started, do you need the bank still? We shouldn't have 2 people in a post. So can we end that bank as soon as possible? Do we need to cover a post? So if you've got a vacant full-time post, do you need full-time hours on bank? Can you do it with slightly less hours for a short period of time? Just think about all those things. And it is to say the same things as you would do at home, managing your monthly finances for yourselves. How can, where you need to make savings, which bits can you slightly trim around the edges? We have to maintain that quality and that performance, and that is absolutely number one. But we need to also watch our finances and make sure that we are doing the things that we need to do. The other element there that we just need to mention, especially coming into this time of year, is our sickness. So again, if you have got people who are off sick, please make sure that you do return to work meetings with people, and any support we can offer staff. There is fantastic resources now on Connect, that if you do have people that are off for particular reasons, there's all sorts of things on Connect now available to support people in being well, and reducing that sickness down. It all does help. So yeah, really important. Thank you. And I will make sure the right bullet points are on there when we circulate the slides afterwards. Thank you very much. I think that's me done. Thank you.
A quick plea, sorry, it's Ingela, I'm just going to butt in. A quick plea whilst Kevin gets the other slides up. You talked about clinic and coding people correctly as well. I think in my previous role as a CNS, we didn't always code people correctly. So even simple things like if they're coming for a wound review or they're coming to have their surgical staples removed, you can tick a box to say that you've removed staples. And actually, I was quite amazed at how much that increases the tariff that we get. So for any CNSs or any teams that have CNSs, yeah, if that message also could be filtered down, that it's not just about multidisciplinary teams, but that's brilliant, but also about if you're doing simple procedures like changing dressings or removing staples, to add that on there. Thank you.
Absolutely, Ingela, thank you.
I'm hoping you can see the slide deck again.
We've got the slide deck. Thank you, Kevin.
Okay, so it should be Carrie and Elaine if they're around to do CCRH. Yeah. Hello, Carrie.
Here. Hello.
Excellent.
Hello.
I'll try not to take your slide deck down during this.
Yeah, thanks. It's a good picture. So, yeah, good morning, everyone. We're here again to update on the Cancer Research Hospital. I'm just going to say a few general things, and then we're going to give you an update on sort of 2 focus bits of work, one of which I'll cover, and then I'll hand over to Elaine. So you can move us on, Kevin, to the exciting picture. So firstly, I just wanted to start off by commenting on the ongoing new hospital programme review that many of you might have heard of. So this was announced when the new government came in, and they are re-looking at all the schemes which are sitting under the new hospitals programme. So that includes the Cancer Research Hospital. There are some schemes which are excluded from that. If you've actually started digging in the ground, or all those hospitals which are known as the RAC hospitals, so I've got this condemned concrete material in, which applies to a lot of the ones in the east of England, Hinchbrook, James Paget, West Suffolk, etc. Now, because we're not a RAC hospital and we haven't actually started digging yet for the Cambridge Cancer Research Hospital, we are part of this review. However, we are one of the furthest progressed schemes still in the review. We've had a lot of reassurance from the national team, and we remain very confident that CCRH will go ahead. So we are waiting for the outcome of this review, which we think will be at the end of October, although it's not quite clear what we will know at the end of October yet. But it is very much progressing as before. We're very much on a tight time frame now, so definitely full steam ahead still. So on that note, we are just concluding the end of the first half of REBA4, which is the technical design phase. So hence I've included this picture which shows all the pipework and all the ventilation systems in the building. So just to give you a flavour of how complicated these buildings are in terms of their engineering requirements, that is what CCRH looks like if you take off the walls and the bits that hopefully we'll see. Hopefully we won't ever see most of this stuff, but there's a lot of complicated engineering that goes in, which is now having to be checked by our architect and engineering teams, as well as reviewed by our estates colleagues, us and a number of other people in the trust. I think we've got about 1,000 documents landing over the next 2 weeks, which we have to review. In terms of what we will see on the ground, we are still waiting for the archaeological surveys to start, and that is tied up with this new hospitals programme review. So we hope at the end of October they will release the money in which we can start that archaeology, and we will see some hoardings going up, and then the development of the full hoardings for the site. But we remain on track to submit the full business case late next year externally. I'll go through internal governance before that, and then for the building work to start in 2026, with our opening timeframe still 2029. So if we just move on from the lovely picture. So one of the 2 pieces of work we just wanted to update you on was around the development of target operating models for CCRH, and this is about how we develop a high-level description of the services and the model of care which we plan to operate in CCRH. And I've listed the areas there that we're hoping to cover. We may well extend it a bit further than that. And this is really about us having an ambitious vision of what we think we will do in CCRH and how that links to other services, of course, not just in the building. We have done some of this work already, and that's those of you who have been involved in our department working groups. We have started to think along these lines already, and we have some input to put into these models. I think we're now hoping that we can maybe be a little bit more ambitious with these, push them a little bit further, and really pick out particularly the areas of how we think we can integrate our care with research, given that is the selling point of the Cancer Research Hospital. But we also need to think about how and where we are delivering services, what needs to be in the building, what doesn't need to be in the building. And particularly we've got an opportunity around digital to think about what are the digital things coming on stream with Epic and how can we make best use of those and plan to deliver them within CCRH. We've got some quite good engagement from the digital team now, and they are looking to see where we can use CCRH as almost a kind of test case for some of the developments that they know are coming in. So it's really about building on the work we've already done, being more ambitious, and then getting these down on paper really, so that we can share those with both external colleagues and internal colleagues. So hopefully something that people are keen to be involved in, and we'll do that through our existing working groups on the whole. I'm going to hand over to Elaine to talk about the other slide. Elaine.
Thank you. So just thank you to Carrie. So Carrie's given us a lot of information around a lot of the practicalities about how we envisage this building will kind of work, and equally a lot of the narrative around this business has this case has been a business case in terms of getting the funding for it. But we kind of recognise that beyond all of this, it's going to really matter about how our workforce from the University of Cambridge and also our NHS workforce, so CUH, are going to come into this building, and how are the relationships and how are we going to work together to achieve a lot of the benefits that we've described in the business case. So we really want to now move to a listening mode in terms of there's lots of the practical things, and we can start to think about some of the solutions for those, but how might we identify ourselves as people that are going to work in this building or going to be affected by this building, and what kind of the cultures and the behaviours that we want to see. So we have now started on some of these conversations. We've had a meeting with our patient advisory group to say to them how do they think that this might work in kind of like practice about bringing these differing workforces together, and we've started those conversations with the senior team, and our next process is to filtrate this down into everybody. So we will be coming out to you to have the conversations around actually on a day-to-day not practical kind of like, how do you feel about it, how can we make this work in kind of like practice, and we've posed some questions there on the right hand side, and these will be some of the questions that we'll come out to ask to you in kind of those meetings. So it's just something to kind of warm you up really, so that you have some time to think about this when it comes towards you in kind of like the coming months. And it's not going to be a short-term piece, so we will, in terms of the next steps for this, is there will be this time to listen, and then we will collate back what we're hearing, where are kind of like the gaps, where do we feel things need to kind of progress. Some of that will be systems and processes, but some of it will be about us having an environment that people feel safe and comfortable to work in, where you can bring your best self in and bring innovative ideas as well. Because when we talk about research and trials, etc., we often think about medicines, but it can be other things as well. So it's trying to kind of bring all that together so that we become more of a family rather than being independent of one another, and kind of break away from being siloed. So I hope you look forward to that piece of work, and we will be coming out to you.
I think just to add, Elaine, on that, I think it's really important that everybody's honest in this piece of work. There's no right or wrong answer, is there? You've asked us these questions this morning, and we've given our honest answers. I think in order for us to really feel the benefit of this new amazing facility, we have to move into a different place, whether that's I hope it's a better place, but we have to move into a different place, and it's really important to be honest about where we currently are with some of these things and our integration between research and our frontline NHS care. And so yes, I would really encourage everybody to give their honest views. Please do not worry that they're not the right views. They are all the right views if they are your honest opinion.
Yeah, no, absolutely. And when we collate that information, we'll do it as thematic analysis. So we're not going to be identifying individuals, you know, so and so said this and said somebody said that. It's going to be very much kind of like a broad and that kind of theme analysis rather than individuals said this, that and the other. So yeah, please do be very candid and just tell us how you feel it is.
Thank you. Fantastic, thank you. Now we would like to talk about something called productivity and efficiency plans. Have I got Andrew on the call?
Yep, sorry, I'm here.
No,
sorry.
That's all right. You were starting just to make me a little nervous there, Andrew, that I was going to have to talk about it. Welcome. Many of you won't know Andrew, but hopefully by the end of this short session, you will, and you'll know now who to contact. Over to you, Andrew.
Brilliant, thank you, and thanks everyone for some time this morning. So Kevin, can you just knock us on one slide, please? So my name's Andrew Goodman and I'm part of the improvement and transformation team. So we're a corporately based team, and at the moment myself and my colleagues, we're supporting the divisions and corporate areas for PEP. My partner in crime, Izzy, is off today, as she would be here as well to kind of jazz up the slide deck for us. But essentially, we're working alongside Jonty Bell, who's in the division as well, just providing some support to yourselves around all things PEP and help us to meet the financial target that we have. So just as the slide says here, and maybe just for the next minute or so, if you could just put in the chat what PEP means to you. This isn't a trick question. When I asked this in a previous presentation, and apologies, some of you have heard this already, so please don't cheat with the answers. When I said PEP, someone put Man City because it's the Man City manager. So that was quite good. I hadn't had that one before. But if you could just spend a minute or two now, just in the chat, just put what you think PEP means to you, please. Yep, that's brilliant. So we've got some good ideas coming through there around efficiency, in-year budget saving, lots of work. Okay, hopefully we'll kind of
couldn't help myself.
Dispel that myth a little bit. You're doing more for less, finance, budgets, etc. Yep, that's good. Brilliant. Yep. Okay, thank you for that. So what PEP is effectively is called the Productivity and Efficiency Programme for the organisation. Some of you, those of you who've been around before COVID, we used to call it the SIP programme, so the Cost Improvement Programme. So basically they're the same thing, where as an organisation we have a financial target to meet, and then this target is then split across the divisions. So for this year, the target was around about 53 million as an organisation we had to meet, and then they topped that up by another 25 million, what they called the stretch opportunity, which was essentially we have to meet the 52 million, and the stretch was so we can have some schemes up and running by the 1st of April. Because as you can imagine, historically, what we were very good at as an organisation, we have a bit of a slow start at the beginning of the financial year because we all breathe a sigh of relief. We've got over winter. We come in with the PEP target. We have breathe a sigh of relief, and we're very slow as an organisation to get going again, which puts us under more pressure. And then when we get to winter time, we've got to think about winter pressures and then the financial stuff. So the stretch, but I believe, was around getting us prepped ready for the start of the next financial year and give us a flying start. So what does this mean for Division B? Our target this year as a division, which including the stretch, is 16 million. So we had a 10.2 target for in-year target, and then another 6 million for stretch. So not an easy task for us as a division to achieve, but it's something that we have been working very hard on and working with yourselves to get to there. So overall, we're aiming for about 16 million by the end of the 31st of March for ready for the next financial year. So that's kind of a brief overview and what it means in terms of PEP and the savings. Sorry, Kevin, can we go on one, please? So we're just trying to put in here a bit about, we talk about efficiency and productivity, and I talk about this all the time in my world, but what does it actually mean? So just to pick up some things here. So in terms of efficiency, we're kind of doing the same amount of work with less. So we're looking at maybe automating our processes. So what can we do with technology? This doesn't mean big, brand new, shiny systems, but what can we do in every day to make the process, to automate it and make it a little bit easier for us? Another thing to pick out there is about how we can streamline and eliminate sort of waste from our processes. So, in your day job, you usually do things and you kind of ask, why do we do that? And could we change it? So it's around just making ourselves a bit more efficient by using automation and looking at our processes and kind of removing things that aren't adding value in the process. Productivity is around sort of being more focused on people and the value. So help to build motivation across the team. So how can we get people more motivated, and that can help boost our efficiency. And how can we kind of foster more collaboration? So how can we build those relationships across teams within the division and across the division, to be more connected and learn of things around best practice and what's working well elsewhere, and possibly things to avoid what isn't working somewhere else and what can we learn from that as well. So that's kind of a high level thing around efficiency and productivity. Probably as another example I can use here. So if we could just imagine that we're in a manufacturing company, and we produced, I don't know, widgets or something like that. If one week we produced 30% more widgets than the previous week, that would mean we're doing well. We've produced more. However, when we come to look at those widgets, if 25% of those extra widgets were defective, that would have an impact. So whilst our productivity is up because we've produced 30% more, our efficiency has dropped down because 25% of the units or the widgets have been defective and not fit for purpose. So it's just a kind of an overview there around about the difference between efficiency and productivity. Sorry, can we go on to the next slide, please? So when we've done this previously to a couple of other audiences, we'd like to put some quotes in there. So we've just put 2 or 3 quotes around efficiency. So the first one there, efficiency without quality is unthinkable, but quality without efficiency is unsustainable. High efficiency does not mean high productivity. Wouldn't I like to, this is my get out of jail free card here, continuous improvement is better than delayed perfection. It's always good to keep going rather than just waiting to that best end result. Another one is, there is surely nothing quite so useless as doing with great efficiency what should not be done at all. And I imagine we all think about that in our day while we're doing things, and can we do things differently. And the last one here from Henry Ford is around improved productivity means less human sweat, not more. So as we know, Henry Ford was part of the automotive industry, and he had great ideas about innovations and how to streamline your processes and reducing waste. But I think what Henry Ford was saying is true productivity is not about working harder or longer, but finding more smarter and more efficient ways to get things done. So it's not, not more human sweat, less, just to be a bit more efficient. So it's working smarter, not harder. So just a couple of quotes there to get you thinking. Sorry, can we just go on to the next slide, please? So kind of really this slide's around why do we have to do PEP? Why do we have to kind of be sort of financially savvy? And it kind of links into what Claire was mentioning earlier around, just if this was your own household budget. So each year the trust is identified tasks with financial savings, which help us demonstrate that we can manage our organisation independently, and we're committed to continuously identification of waste and within our processes and the things we do, and tackling inefficiencies. So we're kind of focusing on 2 main areas at the moment around productivity opportunities. and some of you will be aware around the reducing the length of stay for inpatients, increasing outpatient activity, and improving theatre utilisation more. And the other area of focus is around cost control and savings. So we're paying particular focus on pay costs, aligning to the business planning position of no growth for 24-25. So why do we want to do this? Well, if we can kind of manage our own house independently and maintaining that local oversight, it avoids the tightening regulatory regime. So I think it was about 8 years ago now, we had that kind of special measures, and just as I came into the trust, we came off the back of that. So if we have that tightened regulatory regime, we're going to triple lock, where all transactions and recruitment activity is agreed by NHS England, which is not a nice place to be. And I think we called it the T3 process once before, didn't we? As I just joined, we're coming out of that. And those of you around, you can remember how how difficult things were and how incredibly frustrating. So if we can evidence that we can manage ourselves independently, we can avoid the triple lock, which I know things are tough now, and I don't underestimate that, but it can be a whole lot worse if we kind of have things imposed on us from the centre. So can we just move on to the next slide, please? So we're talking about PEP, but actually in real life, what does that mean? So here we're giving you some examples, and some of you will know that we're working with you to look at some of this stuff. So reducing cost or cost out. So that doesn't necessarily mean kind of removing staff and moving staff around. This is reducing costs is around looking at your contracts that you have. Can we reduce the price of the contracts that we have with external suppliers? Can we negotiate around that and reduce those prices? Could we reduce the price of consumables? We've got some examples there of PICC lines and IV bags and contrast agents. Now, some of the teams we're working with are doing that, and looking at different pieces of equipment or consumables and get a price reduction on those kind of thing. Income generation. So can we do stuff for paying patients and private patients? Can we provide a service to an organisation where we get paid for? But I think we've all also touched on this earlier. It's also important. I think Ingela raised the point. It's important that we document things correctly on Epic, so we get paid for what we do. Because if this, if we were had our own businesses and then things like that, it's absolutely vital to get paid for what we do. So, tick those boxes if you've done a procedure. Clearly articulate in notes or elsewhere on Epic that if you are treating a patient, say for nausea and vomiting, that we've given them medication. Don't just say patient has nausea and vomiting, because the coding team won't be able to pick up on that. So we need to be quite explicit in what we say. Again, another example, if patient has back pain, the coding team won't necessarily pick up that we've treated that, even though you've given the medication. So it goes, actively treating patient for back pain. So it's just subtle differences that we can do that make sure we get paid for what we do. I mentioned there providing service to an organisation. So we've got the AOS line that we provide for Bedford at points during the day. So again, it's an opportunity there. Better use of digital and technology, and we're kind of looking at that for the new hospital. But how can we use MyChart more effectively? What can we do on Epic to make things better for us? Smart phrases, or can we get MyChart to send digital appointments out rather than letters? Can we use MyChart for the pre-appointment questionnaires and things like that? MyChart has loads of functionality. Some of it people have struggled with, but actually I think there is an absolute benefit for teams using the functionality. So if you need to know more about MyChart, please reach out to the digital team or myself and we can make those links. Some of the teams that we've identified is around using the admin teams to do clinic prep for you. So in my world, I'd call that data collection. So can we have the admin teams making sure that we've got the blood results in? Have we got the scans done and reported on, and gather that data ready for nursing or clinical colleagues then to review that ahead of for the outpatient clinic? So again, it's just making sure that we've got the right skill in the right place at the right time to do the right things, but also then it makes the clinic appointment work better. We're not getting people to come in to go away again because we haven't got the right things in place, which then reduces the amount of follow-up clinics and stuff. I mentioned automation earlier. So an example of automation is around possibly data analysis and generation. That data generation you have to do. So I'm aware that we will have to do lots and lots of reports on what we're doing. and working with one of the teams that we identified that they spend an awful lot of time pulling data from Epic, export that into Excel, and then having to do sort of dashboards and reports, etc. There is a way that we can do to automate that process for you. So we can generate, you have to go into Epic still and generate the report, but we can use some colleagues in the improvement team who are very kind of clued up on Excel. Once that report's been pulled from Epic and placed into an agreed shared folder, they can set up the spreadsheet so it automatically pulls that data in for you, so you don't have to go in and do it yourself, and then just goes and produces all the reports that you need. So they're an agreed, once we know what reports are needed, how you want the dashboards to look, we can automate that process for you. That actually you just go in and pull the data from Epic or checks or wherever you want to, but put it into the shared folder, and then the spreadsheets will do everything they need to do for you. Then you can go and present it rather than you manually keying all that work in and all that data entry. Another example of that we've got around that is robotic process automation that some of you might have heard, or virtual workers as they're called, or I like to call it BOPA, back office process automation. So if you're doing manual data entry from one system to another, maybe from Epic into another system or vice versa, we can get the robots to do that for you. So they can do that data entry for you. They're great. They're kind of a manager's dream. They do exactly what they're told 24/7, never go on holiday, never go off sick. But they can just do that automation and that data entry, and then freeing up people to do other stuff, which is far more exciting and fulfilling. So there is some stuff around that we can do as well. And just an example of some other stuff we're doing with teams is looking at, can we use an online booking system so people can book in appointments because they're not on Epic, because it's for screening services and things like that. So rather than using the national system and using the telephone calls, can we get people to book in online, and it does that for us automatically? And using the text messaging service, we've got 2 systems in the organisation. So rather than sending text messages manually, can we use the systems to do that for us? So there's a little bit, it reduces a lot of the admin work around that. So, you know, as we've got there, small things make a big difference. They don't have to be whizzy, brand new products or IT things. You know, just look at your processes, look at what we're doing day in, day out, challenge yourselves why we're doing that. Is it in the patient's best interest? And what can we do around making things different and better for ourselves? And then I guess it's just kind of at that point, you know, if you have those ideas, please reach out to myself. And sorry, Kevin, can we go into the next slide? I think I've got it in here. No, so if you can reach out to myself and Izzy or John T, any ideas at all, please let us know, or any things that you're thinking around and working up, please do let us know. As a division, we're in a really good place at the moment. We're about 3 million short of our target. You know, say it quick, it doesn't sound a lot. And we're working actively to close that gap, but also now we can use this time to get ideas ready for next financial year. The targets come in for next year, but if we can start thinking of things that take a little bit longer to work up, but we can think of those things now, that puts us in a really good position for next year and kind of starts us on the front foot, and then, you know, we can carry that forward. So any ideas at all, just drop us an email, and then we'll get back to you and we'll take it from there. Excellent. Thanks very much for your time.
Thanks, Andrew. And I guess just a note on that, even if you've got an idea and you're not sure if it is a PEP or how to figure it out, any ideas, isn't it, Andrew, as raw as they come?
Absolutely. Yeah.
And then Andrew and his team can work through them and understand if we can count them or not. So, you know, the examples that we've already had in the Directorate, we've had a piece of equipment within urology that we're going to buy cheaper equipment. It's a consumable for a test, so fantastic saving there. We've got some of our robotic equipment we're using less of, so again, it's a saving there. So things like that are really fantastic ideas. Thank you very much, Andrew, and please utilise Andrew's offers of support.
Yeah, absolutely. Use and abuse us. Please do.
You've heard it here first. Thank you very much. I'm very conscious of time, but Ingela.
Lovely, thank you. So I'm going to do a very quick whistle-stop tour. A little sort of plea and introduction from myself. I think this is only my second all-staff briefing. I came into post end of April, so I'm just hitting my sort of 4 or 5 months target now. You may remember Hannah Brown, who was lead CNS before me. I think with her leaving and my coming in, they did restructure the teams a little bit. So I predominantly now look after the lead CNSs within the cancer services. So if you haven't as yet met me, or you would like to meet and greet with me, I don't want to be one of those cancer nurses that no one looks or knows what I look like and no one's met. So if you want me to come and have a little sit in with your teams by way of introduction, I'd be more than happy to do so. I've worked my way around quite a few of the CNS teams, so just drop me an email, ping me a line, and we'll get something arranged in the diary. So I just wanted to do a very quick whiz through about the Cancer Patient Experience Survey. You can get, thank you. Just by way of introduction, I'm not going to focus on all the improvement plans. I'll save that for the sort of the directorate meetings that we have, and the more kind of structured ones from the trust, where I've got to present improvement plans. But really just to give a little bit of an overview as to why we have them, why they're useful, and how everyone pulls together regardless of where you work in the Cancer Directorate in regards to helping these experiences kind of come to fruition. So we've been doing it now for about 13 years. It is a survey run via the Picker Institute, so it's not something that we do within Addenbrooke's, and we don't kind of send the surveys out. The Picker Institute does. Last year, so we always work a year behind schedule. So the results that we're looking at now are the 2023 results, and they were sent out to 132 trusts. And the sample includes everyone aged 16 and over who is an NHS patient with a confirmed primary diagnosis of cancer. And then they do these audits or send out the questionnaires between November 23 and February 2024. Next slide, please, Kevin. So why does it matter? I mean, I suppose first and foremost, it highlights areas of concern, but it also looks at areas for improvements. It also benchmarks national data. So some of you, I'm hoping most of you will have heard of the Shelford Group, of which Addenbrooke's or CUH is part of. And that means we're currently in one of the 10 top performing trusts nationwide across many different sort of fields. So it benchmarks national data to see, are we bucking the trend? Are we similar in experiences to other trusts? And it helps the government with prioritising some of their funding streams. And first time this year, we looked at deprivation data as well, so that we can see what the underserved populations, like the homeless and the travelling community, and also prisoners, and how they are experiencing our services, so that we can find things that we can do to improve them. And that's where my improvement plan comes in, which I won't bore you with today. Next slide, please, Kevin. So really, I just wanted to highlight, one more click, please. You can click through all these exactly. Some of the good stuff that came out of the survey, and these are direct quotes from the patients themselves. So any errors in spelling and things like that is not my typo, it's theirs. But in essence, even as a trust, 10 is the maximum score that you can have for Cancer Patient Experience Survey. And at Addenbrooke's, we scored a 9 out of 10. So this was my first Cancer Patient Experience Survey that I've had to look through and come up with the sort of improvement plan. And I was actually bowled over by just the high standard of care and the fantastic level of service that we provide to our patients. And I've highlighted some of them about the teams have been very professional and treated me as an individual and not a disease, that we're an exemplar of how cancer patients should be treated, and that everyone, which is kind of what I wanted to highlight, that everyone from the consultants and the various teams that have done MRI tests and CTs and the diagnostic side of the pathway, we wouldn't be getting all these fantastic results if it wasn't for everyone in every part of the pathway sort of pulling out the stops and doing the very utmost. So thank you to everyone really who's been involved, from diagnosis to treatments and beyond. And then my final slide is a little bit on touching on where we could possibly improve and what has been less useful to cancer patients. And again, I've highlighted some of them there. So one was told by telephone that I had cancer. And I think we need to be conscious that these are human beings and individuals that we're dealing with. And I suppose what I always try and do is, would I want that to happen to me? Would I want to be told that I had cancer via telephone, or my mum, or anyone like that. So just to be conscious of how and when and where that we give those results. Sometimes patients choose to themselves, and if it's their choice, absolutely fine. But I suspect not all of them are. And then the other one, which isn't really a complaint, but I thought it was a lovely quote, and just to think about what we're doing and do we have to change that appointment, or is there another way of doing it, is stop changing times of appointments. I'm trying to live whilst dying, and I like forward planning, not change. And that just really struck a chord with me, because I think, you know, we're all here to provide a service for our patients. We're all here to help people. And actually, if we're causing them not harm, but if we're causing them to have to rejuggle things, a lot of our patients can't drive, so they're then reliant on other people to take days off work or arrange transport. So just a little bit of food for thought, really. But the final note is, I think we're all blank and amazing, and a 9 out of 10, I think, should be celebrated. So I just wanted to pass on my thanks again, and I will stop there. Thank you.
Thank you, Ingela. I was going to say a fantastic quote, but I'm not quite sure that's the right word. It is very much a quote that we should all probably remember, shouldn't we? It's a good way of wording it. But yeah, brilliant results on a survey, everyone. So it certainly does show that all the work that you do is really valued and appreciated by our patients, which is the main thing. Thank you. Kevin, are you doing this bit? Am I doing this bit? Should we double act?
We can double act if you like. So
you can epic upgrade.
I can epic upgrade. So the next epic upgrade takes place on the 10th of November. Yes, it feels like we've only just had one. We're doing 2 a year now, so they will come around quite thick and fast. Hopefully it's nothing too major. I sent out the kind of headline changes in the bulletin last week, so if you haven't seen those, have a look through those. The training packs and the playground should be going live today. There'll be more in the CUH comms about that. But the plea is to make sure our business continuity backup PCs and everything is available and ready. The plan is not to have to use any of that, but obviously if they take Epic down, upgrade it, and then can't get it back up again, we'll go into backup situations. So make sure if you need, the biggest problem last time was the lack of toner. So if you need toners for your areas, get your toner orders in early, because they had problems getting them last time, and with the late delay in that caused a knock-on effect. So toners. So just check your backup PCs are available, and make sure everyone in your areas knows that Sunday the 10th of November is upgrade. It'll be in the night again as usual, and anyone working on our wards needs to be aware of that. That's epic upgrade.
And I guess anybody that comes in then on the Monday morning, things may look different when you log into Epic. So yes, just please have a look at what's going to change for you. Shall I do flu vaccination clinics? So I hope all of you have been to the old hairdressers. I was slightly shocked that the hairdressers was no longer there. So shows how much attention I pay. But please go to the old hairdressers in the concourse for your flu vaccinations. They are wonderfully quick and efficient. I managed to bag myself 2 free pens and a sticker. So see if you can do better than me while you're there, and please get your flu jab. I think Kevin did again put in the briefing last week that national advice is that we will not be receiving COVID vaccinations this year. So obviously if you are eligible for a COVID vaccination, your GP, I presume, will have already been in touch with you to go and get them within your community, but we will not be being offered them via work.
I'll do this.
I'll let you do that one. Yeah.
Gina is on the call, I know, so she'll be twitching now that I've put a picture in here without her knowing. But I just wanted to remind everyone of the Cancer Patient Partnership Group and the wonderful big team we have there. They're always looking out for new members, and so if you've got any patients that you think would be interested in joining the CPPG, please do put them in Gina's direction. And likewise, if you've got any projects or anything coming up, please also make sure we get some patients involved in that. We want to work in co-production, so actually having the patients in there doesn't matter if it's not at the start. If you've started something and you think, oh, we need patient input, please do reach out to Gina, but we'd love to be there from the start as a CPPG. So just a plea there around CPPG. And Vanitha,
Thanks,
you've
Kevin.
got your hand up.
We've got some questions.
Yeah,
Vanitha.
go on, Vanitha.
Yeah, so Rina, just regarding the COVID vaccine, I think you can get it booked through NHS app if you are frontline workers, I think.
That's helpful.
Booked, so.
Thank you for noting that. Thank you.
And then the other one, I know we've talked about small changes, big things, and all about different changes. But we do also have Innovation Change Station in the Directorate. It's been around for a long time now. It's how we've got some things done around business cards to support our CNSs, around one of the staff rooms down in oncology. So if you've got any ideas for anything within your areas that you want to do, want to change, we can forward those on to Andrew and his team as well, so they can be involved in them. But also we do this in co-production with our patients. We also work with ACT on it. So we do get some funding in from ACT. All the business cards are funded completely by ACT. So they're also very supportive. So any ideas, no matter how big or small, come through that as well. And we'll ping them on in all the right directions as well. So there's lots of routes in for changes there as well. So just a plea on that one. And then I would say, Claire, do you want to do this one? But CUH Awards, well done to everybody who's been nominated, and well done for those who have reached the short list. They're listed there from the C9 board team, and Kirsty and the ONC team there with Duane, but also Claire is on that list as well. The ACT nomination. So well done and good luck to all of those who are at the ceremony in November.
Thank you, Kevin.
There's no picture of you though. That's
for those that don't know, I'm not very good with events like this, which yes, I'm hugely appreciative, but not good with events. Have we got another one? Fantastic. If anyone's got any questions, queries, I'm very conscious of time, but please pop them in the chat. I just wondered, Kevin, if I could just take over screen sharing for a second and just remind people. If you're really stuck with where to go for things and you don't know the answer, on the main Connect page, if you type Cancer Directorate in the search bit at the bottom, it comes up with a page that looks like this. And on the right hand side, this is where all of our information is. So it can tell you about who is in the Cancer Directorate, where things are. All of our information is on here around vacancy authorization processes. You can click on all the links here. All our risks and incident processes are on here. Basically, everything to do with the Directorate is all on here for you. Click away and find things. If you're really stuck, of course, email us. And the link is on here. If I can navigate backwards again, the link is on here somewhere or other to the senior team email address, but it is all here and you can find everything you need. So please check there first. It's a really fantastic set of pages that Kevin and his team have done. So thank you very much.
And if you've got any suggestions or anything you can't find, anything that you want on there, just ping me an email, let me know, and we'll see what we can do.
Fantastic. With about 30 seconds to spare. Well done, everybody. Thank you very much for those that presented and coming. If you'd like to present for future meetings, please let us know, and you're very, very welcome. Particularly good things that we've done. It's always brilliant to share. And thank you very much again for all you do. It really, really does make a difference. Enjoy the rest of your Monday and the rest of your week. Thank you, everyone.
Thank you. Thank you.